Romain David. So you will present us an algorithm to determine which muscles are involved in equinose varus foot.
Okay, hello again. Thank you to the moderators. I'm delighted to talk about this afternoon about a proposal for a diagnostic. I'm delighted to talk about a proposal for a diagnostic and therapeutical algorithm for the spastic and retracted equine foot. To start, it's necessary to have a common languages. Today, I will only take to you about the pure equine, that is to say, only in the sagittal plant. During this presentation, we will not discuss other forms of equine, like the video, varus or varicose equine, which just focus only on pure equine. As you know, there are two major concepts in neuroorthopedics. Hypertonia, a component of pathological hyperactivation, including spasticity, dystonia, co-contraction, and retraction, a structural orthopedics component. It is sometimes difficult to demonstrate hypertonia and retraction to make a therapeutic decision, especially in complex forms. We gathered a French panel expert in neuroorthopedics led by the 5 board members with different specialties, orthopedic surgeon, neurosurgeon, PRM, podiatrist, in order to sharing of different point of view and create step-by-step an algorithm. This algorithm was submitted for validation to a group of 53 PRM specialists during a neuroorthopedic day. So this is the first step, equine foot. The first question is, the equine, is it useful? And because when you have equine, when you have inequality of length of the lower limb, hip flexum, knee flexum, the equine can be necessary and useful, as you can see of this video. The next step is to check different elements for global evaluation of the patients, such as history of previous treatment of the equinus, botulinum toxin, surgery, analysis of structural and functional shortening of polyarticular muscles, analysis of segmental legs and torsion, and radiological warnings. There is 3 components, 3 origins for the equine foot, in-foot, forefoot, and combined, when they are an origin of in-foot and forefoot. Each origin requires an evaluation of the specific muscle compartment. For the in-foot part, it is the evaluation of posterior and anterolateral compartment. For the forefoot, an evaluation of posterior and plantar compartment. And for the combined part, the evaluation of posterior and plantar compartment, like the same of in-foot or forefoot. The next step, after the evaluation of posterior and anterolateral compartment, for the posterior compartment, we use the silver skull sign in order to the silver sign in order to make to distinguish the part of the gastrocnemius of triceps surae. Sometimes you have a tremor sign with hypertonia. It's easy, and sometimes it's retracted. It's necessary to have an evaluation of anterior and anterolateral lodge. And if you have a joint cause, you make a radiography. Next, if you have an hypertonia, step 4, the treatment. If you don't have, if the part is difficult to hypertonia or retraction, you can use an anesthetic block, a selective anesthetic block. And next, if you have hypertonia, the first treatment is botulinum toxin, but you can use also orthosis on individual heads, or the surgery treatment is a selective neurotomy. If you have a retraction, the treatment are an elongation of the gastrocnemius blade, or if is triceps surae, according to the Silverthorne, you can have a calcaneal tendon lengthening, percutaneous. With the evaluation of anterior and anterolateral lodge, we have three cases, a normal activity, an hypertonia, and a deficit. And the combination can make an objective on purpose for the patients. And you can use botulinum toxin if you have hypertonia, orthosis on technical aids if you are deficits, and you have a surgical proposition, anterior hemitibial transfer, or selective neurotomy if you have hypertonia, and transfer posterior compartment for the tenodosis effect. For the joint causes, the concept is simple. Tendon release to unmask the articular part, and next you can make an arthrolysis or an arthrodesis. For the forefoot origin, evaluation of posterior and plantar compartment. With the intrinsic concept, if you have a doubt, you can make an anesthetic block retromalleolar in order to make the part of intrinsic, of extrinsic, or intrinsic. We have anatomically three parts. The first column with an evaluation of abductor of hallucis and adductor of hallucis. In the central zone, central column with anteroceus, quadratus plantae, short brevis digitorum muscles of hallucis of digiti minimi foot. And the fifth column for abductor of the digiti minimi or adductor of digiti minimi, foot, of the foot. And you make an extrinsic evaluation of the anterior compartment, extensor digitorum, longus and brevis, tibialis anterior, and fibularis tertius. As the same is in foot, you can evaluate the joint cause with radiography. For the treatment, when you have hypertonia of intrinsic muscles, we have two possibilities. You can use the botulinum toxins, orthosis on technical enzymes, and the second option is a disassertion on tenotomy. The intrinsic evaluation, you have three cases, normal, hypertonia, and deficit. And you can use botulinum toxic, orthosis, on technical eggs, or an extension transfer on a clotenotomy. It's in order to defend the objective with the patients, the research of stability, and sometimes you have a talk law in treatment and complement. For the joint causes, the concept is the same, tendon release to unmask the articular part, and an arthrolysis and arthrodesis. For the combined foot, we have four possibilities. In foot with hypertonia, forefoot with hypertonia, in foot with retraction, forefoot with retraction, in foot with hypertonia, forefoot with retraction, in foot with retraction, and forefoot with hypertonia. For the treatment, you can use a diagnostic anesthetic block if it's necessary. The first treatment is botulinum toxin, intrinsic then intrinsic, and it's not an you can use you can make also a selective neurotomy. For the second part, the surgery of intrinsic is the first step, and next you make an evaluation of residual intrinsic component in order to evaluate hypertonia or retractive. And the second time, you can make a surgery of intrinsic muscles. For the third part, you can use a diagnostic anesthetic block. The first treatment is botulinum toxin for intrinsic muscles, and next, a tenotomy of the first of the fifth of the central columns of intrinsic muscles. For the next part, you have two possibilities, tenotomy of intrinsic muscles and botulinum toxin of intrinsic muscles, or you can use technical aids in order to treat the four infoots and botulinum toxic for intrinsic muscles. So we have a proposal to algorithm in order to diagnostic and therapeutic for the equine foot only in the sagittal plant. Thank you for your attention and thank you for my masters.
I have a question. Did you? I already had this question. Can we do some special selective gastrocnemian treatment?
In case of hypertonia or retraction?
Hypertonia, yeah.
Hypertonia, if you, as you can see on the algorithm, the first treatment is botulinum toxins.
No,
and next,
my question is not bad English. Can we do some ténotomie of gastrocnemian medius or gastrocnemian latéral? Est-ce que tu as des spécificités? Est-ce que tu penses que des fois on peut avoir des spécificités sur la ténotomie d'un gastrocnémien plutôt que de l'autre?
Peut-être on peut poser la question à Philippe de Normandie, mais at this moment we can treat the gastrocnemius blades entirely, not specific of different muscles. Maybe at the future, with the modelization of Antoine Perry, for example, new techniques can arrive.
Thank you for the presentation. And trying to answer your question, years back we did actually a very detailed assessment of the differential in the muscle activation using dynamic EMG of medial gastrocnemius versus lateral gastrocnemius. And we actually did selective nerve blocks to either head to try to address this particular problem. We found that only in about 3% of all the patients, this was like 300 patients that we had data on, where we were able to see a difference. So the great majority, medial and lateral, are very much in sync. In the spastic population, that's not true in normals, but in the spastic population. Can I make the comment from before? Because I want to answer the question about gait analysis. Does gait analysis play a role in muscle selection? And Marianne Keenan and I did a study years back. We published this study in the early 90s. We looked at, I think it was 30 patients, where the patients went in and were evaluated by the surgeon first. The surgeon did his full assessment or her full assessment and wrote down the treatment strategy. I'm going to lengthen this muscle. I'm going to release this muscle. I'm going to not do anything to this muscle. They wrote it down, and then we took the patient to the gait laboratory. We performed gait analysis, and then we send the report to the surgeon and the patient back to the surgeon, not with their old records, so they had no idea what they had written before. We assume that surgeons have long-lasting memory, but they don't have such a long-lasting memory. Repeat that? Same surgeon, yeah. In fact, we did this with 2 surgeons. Each patient was assessed by 2 surgeons. Marianne Keenan, who was by then a very experienced surgeon, and David Fuller, who was less experienced. And we looked at them. They each did their algorithm of treatment. I took the piece of paper, put it in a folder. Patient came back now, a month later, with gait analysis. And they redid now the study with gait analysis. 50% of the time, they changed their opinions. 50% of the time, they changed their opinion. So gait analysis had... So this is a very interesting point. Was it in the wrong direction? First of all, what we saw were 2 important observations. Highly experienced or less experienced. With gait analysis, they ended up in the same place. Now, it doesn't mean who was better or not. I'm just saying they ended up in the same place. When we look at outcomes, and of course the outcomes are difficult because you're quantifying a variety of reasons for the deterioration in walking velocity, but we use walking velocity. We saw improvement in all of them. So we are assuming that the surgery was correct. Now, we didn't do a group where we said, no gait analysis and let's see how lousy results you get. We didn't do that part. But it appears that gait analysis does play a role in helping select the muscles in a more appropriate manner. So that's the answer to that. That was published in Foot and Ankle. And the first author is Fuller, David Fuller.
Va répondre. Deux remarques, je vais être très court. Sur les gastrocnémiens, ils marchent probablement dans le même temps. Maintenant, c'est des sujets qu'il faut qu'on travaille. Il y a une telle différence quand on les dissecte. On a souvent posé la question, il y en a un gros et un tout petit. Et maintenant, on voit bien qu'il y a une composante varisante qu'on a beaucoup tendance à attribuer quand même au gastrocnémien médial. Donc par rapport à la question, est-ce que dans l'avenir, il y a peut-être des choses spécifiques plus importantes à faire quand on fait une ténotomie sur un médial qu'un latéral, si ce n'est que même quand on fait les percutes, on sent très bien que l'aponévrose médiale va beaucoup plus latérale que l'aponévrose du gastrocnémien latéral. Je ne sais pas si vous voyez vous dire, ça va beaucoup plus loin latéralement, ce qui peut expliquer la composante varisante.
Merci. Another question?
Et puis, la deuxième remarque par rapport aux chirurgiens, je ne sais pas, mais est-ce que les chirurgiens, est-ce que l'analyse de la marche a permis d'analyser le patient marchant? Je me fais la critique à moi-même. Depuis que je consulte avec des médecins de rééducation, je regarde beaucoup plus les patients marcher avant de les examiner sur table. Donc en quoi c'est... je veux dire, où est-ce qu'il n'y aurait pas un biais? Et le fait de regarder les analyses de la marche, c'est comme si on voyait beaucoup plus ce patient marcher. C'est quand même pas beaucoup dans la nature des orthopédistes, en tout cas en France. Je parle encore à moi-même.